Hello and welcome to our presentation outlining our research on 5-year outcomes with transurethral bipolar enucleation of the prostate, or TURP. Rapid adoption and familiarity with instrumentation makes TURP a viable alternative to Holmium enucleation, or HOLEP, in those unable or unwilling to endure the HOLEP learning curve. We have nothing to disclose. Transurethral enucleation procedures for benign prostatic hyperplasia, or BPH, can effectively remove large volumes of prostatic tissue comparable to open simple prostatectomy. The most common enucleation procedure is the Holmium Laser Enucleation, or HOLEP, but the learning curve is steep and has thus not been widely adopted. The senior author in this study, a non-fellowship HOLEP-trained urologist, was asked to learn HOLEPs, but quickly abandoned them after approximately 6 months and 15 HOLEP procedures, when operative times and surgical outcomes were not improving satisfactorily relative to their standard transurethral resection, or TURP, experience. Wanting to continue enucleations, however, the enucleation principles were incorporated into more familiar resection bipolar devices, first using the bipolar button electrode and later the plasma loop electrode. The primary anecdotal advantages expressed by the senior author were immediate familiarity with the instrumentation, ability to use enucleation and traditional resection techniques interchangeably, and the ability to perform antegrade and retrograde manipulation of the prostatic tissue during blunt dissection and adenoma enucleation. The purpose of this study is to review our 5-year experience with transurethral bipolar enucleation of the prostate. We hypothesized that operative time would decrease and resection volumes would increase over the study period, and surgical outcomes would be similar to those reported for standard transurethral resection procedures and HOLEP. This was a retrospective review of a single surgeon experience with TURP. From 2015 to 2018, the Olympus plasma button was used for this enucleation. This was switched to the Olympus band electrode in early 2019 after negative changes were noted in the durability of the plasma button during the enucleation process, such as bending and breaking of the electrode. The primary study outcomes included operative time, tissue resection, PSA drop, symptom improvement, maximum flow rate, and post-void residual improvement, assessed both as a median and over time to assess for the learning curve. Secondary outcomes included rates of de novo stress urinary incontinence, de novo erectile dysfunction, postoperative transfusion, secondary operations for perioperative complications, and reoperations for recurrent or persistent obstructive voiding symptoms. Finally, a sub-analysis was performed in the cohort of patients that presented in urinary retention requiring either indwelling or intermittent catheterization to see how many became catheter-free post-TURP. All statistical analysis was performed in Excel. 208 patients underwent TURP, 154 with the plasma button and 58 with the band electrode. Prior procedures had been performed in 12% of the patients seen below. Median operative time was 80 minutes. The median amount of tissue recovered was 20 grams. There was no significant changes in either operative time or tissue resection during the study period, seen in the figures below. Prostate cancer was detected in 13 of our patients. 3 of these were grade 3 or higher. The median decrease in PSA was 67%. Perioperative transfusions were required in 3 patients. 2 of these required a secondary procedure for bleeding and/or clot evacuation. 4 of our patients underwent a secondary procedure. These included bladder neck contracture, fossa navicularis urethral stricture, and prostate regrowth and/or inadequate resection. The median improvement in urinary flow was 8.6 milliliters per second. The median decrease in post-void residual was 106 milliliters. 93 patients were initially catheter-dependent preoperatively. 84 or 90% were able to discontinue catheter use after TURP. 4 patients developed de novo stress urinary incontinence. Half of these required catheterization preoperatively, and none required intervention due to this. 21 patients required de novo PDE5 inhibitors. However, 17 of these had indwelling catheters preoperatively, and their erectile status was unable to be assessed due to this. 166 patients were on prostate and/or bladder medications preoperatively, 107 of which
were able to come off their medications completely postoperatively. The majority of those remaining on medications were on anticholinergics and or muscarinics for persistent urgency frequency symptoms. In this single-surgeon retrospective study of 208 consecutive tube procedures performed by a non-fellowship trained urologist, comfortable with transurethral procedures, but unable and or unwilling to reach the HOLEP plateau learning curve, surgical outcomes were comparable to HOLEP. While there are likely surgical and perioperative advantages of HOLEP to tube, that cannot be demonstrated here. This study shows that tube may increase the likelihood of incorporating enucleation techniques into clinical practice by those without the necessary technology or the means to endure the HOLEP learning curve. This presentation is dedicated in memory of Brian Barnes, a urology resident at the University of Iowa and one of the authors of this abstract, who committed suicide earlier this year. He will be greatly missed as a colleague, teacher, and friend. If you or anyone you know is thinking about harming yourself or attempting suicide, please tell someone who can help right away. Thank you, and I hope you enjoyed our presentation.